I'm delighted to be here with my esteemed colleagues. I'm Ira Herman from Tufts University School of Medicine. To my immediate left is Michael Bain. To his immediate left is Dot Weir, and then Kathy Milne is on the far left. So what are our learning objectives this morning here in San Antonio at this amazing convention center? We want to make sure that upon completion of the program that everyone, if not already, will at least know and be able to tell at cocktail parties tonight of the physiologic process of enzymatic debridement. And I will share some information which may actually teach a little bit about how enzymatic debridement may go beyond debridement itself to active healing. We'll want to actually make sure that everybody understands the role of debridement in the inpatient long-term care and acute care settings. We want to explore the role of debridement in combination with other wound care modalities, as all of you practice in your clinics, what might be combination therapies. And then, of course, the pharmacoeconomics being what they are or aren't. We want to make sure that everybody understands what might be the cost-benefit analysis, that if you take the time on the front end, it may save money on the back end. Again, we have disclosures, everything, all of that, no product information, recommendations will be inferred. You have all of our disclosures in the documentation in front of you. So let's get started. As I mentioned already, we know that debridement removes necrotic tissue, dead and senescent cells, and excessive bacterial burdens. It also obviously represents an early step for the activation of healing, not just in diabetic ulcers, but also in wounds that are insufficient, vascular insufficient, or in decubitus in pressure wounds. And that there is anecdotal as well as good clinical evidence that continual ongoing debridement may actually keep the wound bed free from healing impediments while fostering the removal of non-viable damaged and infected tissues. But for us, at our Center for Healing in Boston, at our School of Medicine at Tufts University, we've been promulgating the notion that the bacterial enzyme collagenase has been extraordinary in its ability through evolutionary time to remodel matrix, and to remodel matrix to give rise to fragments that then can actually be participatory or actually drive what could be the cellular responses to injury, to foster tissue remodeling, and actually to promote wound healing. So what's the evidence for that? So several years ago, Kathy Riley and I published a paper in Journal of Burns and Wounds, and this was really the culmination of work that had been ongoing since last century, I hate to say, but true. And we were able to show in preclinical models, in cell-based studies as well as in animal-based studies, that the enzyme present in sample, this Clostridial collagenase, when purified away from its other non-specific proteases, neutral cysteine proteases and other proteases that were present in the preparation, that we could actually stimulate human keratinocyte proliferation several-fold over controls by just taking the extracellular matrix produced by those cells and digesting it once with this purified enzyme. And that if we actually had a trace amount of that enzyme, that Clostridial collagenase, in the growth media, together with the other goodies that the cells like to have in order to stimulate growth, we could actually get a fourfold induction in cell proliferation over untreated matrix controls. That the crude enzyme was quite good at doing this, but clostripain wasn't. And in fact, at the time, we were interested in understanding the regulatory role that papain and urea, chlorophyllin, might be playing. In fact, that was actually a killing agent under the experimental conditions that we were testing. So these exciting data suggesting that the bacterial enzyme collagenase could promote keratinocyte remodeling by promoting proliferation was then taken to a swine model of healing. And here you can see, again, representative examples of full-thickness excisional wounds. I know I'm happy that everybody finished breakfast so that you can look at these wounds without issue. So here, a 10-day time point, representative 5 wounds, full-thickness excisional wounds, under control conditions where the wounds were just covered and moist. Bacaplamin, or the Regranix treated wounds, 5 examples. Solocyte, the excipient that we embedded our collagenase in, and the collagenase itself. And you can see, without any uncertain terms, the collagenase was able to actually promote healing, complete closure in virtually greater than 9 out of 10 cases, 97% of the wounds were completely closed. The cratering that you see along the edge between the uninjured and injured sites in the Collagenase tree wound were actually much better looking. And so the preclinical data was fairly compelling. In vitro, we could promote keratinocyte growth and migration. We could promote angiogenesis, and then in vivo, in this preclinical model using swine, we could promote healing. So this led to the notion that there are bioactive matrix fragments that play instrumental roles in promoting the cellular responses to injury, both in the dermal compartment by stimulating vascular remodeling and in the epidermal compartment by stimulating the migratory and proliferative responses. And we believe that these fragments may play a really pivotal role in helping to interconvert what might be these chronic non-healing wound beds into wound beds that might be actively able to heal by creation of what could be bioactive wound healing fragments that are originally generated by the clostridial enzyme itself. And so this hypothesis has been tested recently, and I'll get to tell a little bit about this here, but tomorrow more, that the enzyme itself produces bioactive wound healing peptides, and we developed a whole discovery and innovation program wherein we could take the matrix, digest it with the enzymes that we were interested in digesting with, and using mass spectrometry, interrogate the sequence information of what might be these peptides generated from matrix, collagenase or not, and then in our preclinical models in vitro on the different cells that are instrumental in promoting healing, and then in vivo using impaired animal models of wound healing. And as we go forward, we aim to actually identify what might be the receptors regulating the responses that we know are taking place. Let me just share quickly with you a little bit of this data. So here are a series of new wound healing peptides that we've created as a result of bacterial collagenase, the enzyme that's in Santal. This enzyme generates fragments, and the fragments we've now identified and resynthesized chemically. And here you can see our endothelial cells doing angiogenesis in vitro in one of our in vitro models. And you can see under control conditions, the endothelial cells don't make capillary-like tubes very well. But under the control of 3 different peptides, TSN1, 8, or 10, the sequence information not important here, you can see that the rate and extent of capillary formation is markedly altered. And when you look at this statistically, you can see that there are many of these peptides that we've now created compared to what might be a gold standard basic fibroblast growth factor or no additions. Many of these peptides are actually far better than the best of the best angiogenic inducers on the planet as we know it to be. So we're extremely excited about the fact that we've now identified what might be the mechanism or the science behind the action of what is now this enzyme that we know works out in an outstanding fashion to enzymatically debride wounds. But in fact, the products of digestion of this enzyme that are resident within the matrix go on to promote healing by stimulating blood vessel growth, by promoting granulation tissue formation, and by stimulating epithelialization by promoting the growth and migration of the epithelial cells within the epidermal compartment. So I'm going to leave you with that and turn the podium to Dr. Weir, who's going to define the role of enzymatic debridement as we go forward in the acute and long-term patient care settings.
All right, well, good morning. Thank you for joining us. It's nice to see everybody here, and welcome to SAWC. I'm going to be talking about, as we talk about the continuum of care, the role of enzymatic debridement, and mostly from an institutional standpoint, as we look at inpatient of all kind, long-term care as well as acute care. You know, these numbers are not that important other than I went looking, and I was really surprised to find that over the last 40 years, our numbers of hospitals, as well as hospital beds, has declined by a pretty significant amount. The average length of stay, and this is what I want to think about, there was 4.8 days in acute care. And if you look at the number of nursing home beds, 1.7 million, there's 1.4 million residents that are lying in these beds. So the bottom line is that we've got a huge problem. It's a snowballing and costly problem. And chronic wounds affect a whole lot of people, 6.5 million. It's claimed that in excess of $25 billion is spent on the care of these people. I've heard it up to 30-something million. But the interesting thing about that is this cost does not include a lot of the things like lost time from work and co-pays, deductibles that have to be met, things like that. So it's a lot of money that's not only spent by our payers, but a lot of money that comes out of our patients' pockets as well. And the wound care product plays a role in that. So we have to think about how long we're sustaining these people or having these wounds stay open when we might be able to do something to move them faster. So when we look at wounds of all kinds, there's so many of these that are lying in these. And the little cartoon is showing a hospital, but again, we can extrapolate that out to just beds in general. I don't know how fast I went on that, but what I want to just emphasize is that good wound care principles don't stop at the door of these institutions. Remember, I said it was like 4.8 is the average hospital stay, for example. And of course, in long-term care, we have them for usually the duration of their life. And so it's important that we continue to be aggressive in terms of treating these wounds and trying to continue them on the trajectory. And just because we lay them into a hospital bed, we don't have to go to something a little bit more less aggressive, waiting for them to go home. And as you know, so many of these patients come in that have other problems, and the wound just happens to come into the hospital with them. So it's important that we continue to treat them as aggressively as we would if they were on the outside. Many of you are already familiar with the concept of wound bed preparation, and when we look at the concept of debridement, what we have is we have a defective matrix. He was just talking about in the very first slide that the problems that we have with ongoing debris in a wound and how important wound debridement plays, what an important role that plays in that. And so our intervention is going to be debridement because what we want to do is get rid of that debris, obviously, and restore a healthy wound bed and encourage the growth of good extracellular matrix proteins and granulation tissue. So our methods of debridement are going to be varied. We all know that there are various approaches that we can make in trying to clean these wounds out, with sharp or surgical certainly being the most rapid. And you're going to hear some data this morning about the combination use of sharp debridement with an enzyme such as collagenase. Otherwise, many times we're using either autolytic or enzymatic, with, of course, biosurgical and mechanical being thrown in there some. But I would never stand up here and tell you that autolytic debridement does not work. It is using the body's own enzymes in order to liquefy the necrotic tissue. But when we look at that, it does rely on the patient. It's not the dressing. It's never the dressing. We have lots of dressings that can create the right environment for autolytic debridement. Would you agree with that? I mean, we have a plethora of things. Go into the exhibit hall this week and you'll see them. But what it does rely on the patient's immune system. It does rely on that patient's ability to autolyse their own tissue, their own necrotic tissue. And most guidelines recommend that if we don't, and the Wound Healing Society are specific on this, if we don't see liquefaction of that necrotic tissue happening, then we need to go to something more aggressive. And so when we look at not being dressing driven, but the fact that we can put an enzymatic and exogenously applied enzymatic ointment on that will selectively debride necrotic tissue, it makes sense, as well as was already mentioned, it can help to prevent the reaccumulation of debris in the wound bed. So when we look at use in any inpatient setting, the good thing about a drug, something such as Collagenase, is it is easy to standardize. Well, it's easy to standardize because there is one that we have to use in the United States, but it can also help us to save costs on dressings, minimizes the use of expensive dressings, and we can use less costly secondary dressings as long as we're creating the right environment, which I'll talk about. It's also easy to monitor. I would not want to be an inpatient nurse for anything these days when I see how pulled they are in so many directions, and if there's a dressing to be done, it's easy to put that off. And when we're using something that's a drug, it's on their medication record. So the drug is scanned, the patient is scanned, and the dressing gets done. But also, it's very easy to teach. This is not a hard procedure to teach to our staff, and we can always get support from the companies that provide them. So when we look at application, again, where you're going to hear data about combining collagenase with other kinds of debridement, it's very important to rinse with normal saline or another compatible cleanser, which I'm going to talk about, to apply it in a thick enough amount. 2 millimeters or nickel thickness is the recommended. By creating and enhancing a moist environment, the enzyme is going to be enhanced and it will work better in our hands. And then, of course, we have to change it daily. So to that end, I love this little acronym that you can help your staff to understand and help us to remember, and that's the word MEND. We want to keep it moist. We want to apply it edge to edge or cover the entire wound, about nickel thickness, and it needs to be changed daily. So that's just an easy way to remember how to maximize the effectiveness of it. But the other way we can maximize it is knowing how to combine these or what we should not be combining these with. You know, we're all really good at this kitchen chemistry sort of stuff, layering things because it makes sense to us. And so we have to be aware of what will or may not be compatible when we're using topically applied collagenase. And to that end, there was an in vitro study that was done. Jovanovic was the lead investigator on this. And if you have not seen this, I would encourage you to go to the Smith & Nephew booth and get this. This needs to be in every nurse's station and every time we're thinking about designing a treatment program for these patients. And again, this is very busy. I don't know how well it shows up on the slide, but this is just looking at the various cleansers. And you might see your cleanser on there. And it doesn't mean, because we all like the spray cleansers, the one that have surface active agents in there, but we don't want to get rid of that. It gives us good mechanical cleansing. But you want to know if the one that you stock in your hospital is on this list. It doesn't mean you stop. It just means a simple rinse with normal saline prior to the application of the collagenase. By the same token, there's various dressings, antimicrobial formulations, and again, I don't have time to go point out specific ones on this list, but before we do the mixing in our hand, 50-50 of a various, with an antibiotic ointment or layering, then we want to know the compatibility with the ointment. And then lastly, looking at our dressings. In the package insert for collagenase, it does talk about the use of heavy metals and detergents. So we don't want to be layering them and mixing them with specific antimicrobials. These are the silver products, but particularly like PHMB, which was on the previous page. It's a fine antimicrobial, but it will reduce the effectiveness of the collagenase enzyme, as well as the IotaFlex and the cadexamer iodine products that you see at the bottom. So some specific considerations when we're using this and we want to enhance it and make it work better in our hands. Something we don't talk about too much anymore is the concept of cross-hatching. We know that collagenase works at the wound bed and will cleave off dead collagen from live collagen right where they meet so that we get all the debris out. But if we have a hard eschar or dense necrotic tissue, I still believe that it's helpful to crosshatch to allow the penetration of the enzyme into the deeper tissues. And again, this is just a series there showing over a period of just about a week using crosshatching and the collagenase and how clean we can get a wound. So again, not wasting those 4.8 days that patient may be lying in our beds. So the other thing that I like to always talk about when I talk about any kind of, whether it's autolytic or enzymatic, is that we have to be aware of what we're going to see when we take the dressing off. And so many times our documentation records have serous, sanguineous, and purulent, right? What does liquefying necrotic tissue look like? It's opaque, it's tan, it may smell. And so we want to make sure that our colleagues understand that this is not a bad thing. This is the expectation when we're using something like this that we know is going to actively liquefy this tissue. So we want to be able to go to our notes narratively and say that we're seeing liquefied necrotic tissue, previous treatment residue, whatever makes sense, so that we don't send that patient on a pathway by calling something purulent. We also know that it's safe to use in areas that may be at risk, someplace where there may be vessels. The one on the right was a lady who had such a low pain threshold that we could not possibly use an instrument to her. And once we used the enzyme and we got it clean, you can see that little capillary that's running down the center of her wound. She wouldn't have exsanguinated if we would have hit that, but it would have been a little messy. So it was just fortuitous for her. And I don't know if this video is going to work or not. No. Well, what you're looking at with that toe is a pulsing vessel that was there that we were just about to put negative pressure back onto. And so fortunately, knowing what the neighborhood is that these wounds are in, AV grafts where the dialysis grafts that we need to get cleaned up, FemPop bypasses, anywhere where we don't know what the vascular status is and we don't want to be rooting around with a sharp instrument, then we have a safety net here. It can be combined with other kinds of debridements. That's going to be already delivered this morning, so I won't talk about it. But it does help healing, as we just heard. Such exciting data that it allows healing to occur simultaneously. So while we're still cleaning up a part of the wound, we have granulation tissue and epithelialization that can be occurring in other parts of the wound. But I think, again, the myth that needs to be dispelled, that it is biologically selective. It is incapable of harming good tissue. Oftentimes I hear about people saying, oh, the peri-wound skin got irritated. But remember, we're creating more drainage many times, and a lot of times people react to their own drainage. And so, again, our secondary dressing, making sure we're creating a moist environment for the collagenase to be as effective as it can be, but also that's absorbent enough to be able to protect the peri-wound skin. And also, there is a good benefit to the fact that it's easy to discharge a patient with a drug. There's a great program that specifically with Collagenase, you can have them do the research, get the patient's information, and actually have the product shipped to their home through a specialty pharmacy program. So with that, I will now turn it over to Dr. Bain.
Good morning. My name is Michael Bain. I'm a plastic and reconstructive surgeon from Newport Beach, California. I'm here today to talk about debridement, as you know, and in conjunction with some of the other things that we do, compression, skin substitutes, wound vacs, or negative wound pressure, rather, Clostridial collagenase, etc. So as a straight clinical person, I look at compression, which we all do on a weekly basis. Oftentimes the nurses do the dressing changes with or without a physician present. Multilayer compression, as we all know, is the mainstay for treatment for both lymphedema and venous patients. And weekly sharp debridement is performed at that time. There's no direct evidence for use of Clostridial collagenase ointment with it. Anecdotally, however, it does work. Oftentimes, in practice, you put a little thicker layer down, put a nonstick dressing like Xeroform that's petroleum-based, so that way the santal does not get absorbed, collagenase doesn't get absorbed into the gauze itself, and rewrap the patient. Really, when you move on from that to other advanced wound care modalities, such as bioengineered skin substitutes, you already have an optimized wound bed. With venous patients, you need to make sure you remove all of the slough. Diabetic, the same way. We want to remove the callus, so that way you can use the skin substitute. Debriding in between the grafts is definitely a contentious area. Oftentimes when you change these graft dressings, you will look at the wound and say, boy, there's a lot of crud in the wound, so to speak. It looks golden colored, and I'll show you a picture of that. The natural tendency for everyone is to remove that product of debridement, that caramelization, off of the wound bed weekly when you do your dressing change. The problem is that it also contains cells, bioactive cells. It has cells that are stem cells that are now in it because of the growth factors in the grafts. You will have angiogenesis and blood vessels also in the area. So one of the things you want to make sure is you don't rinse that stuff off. Here's a picture of a patient who had a skin substitute, and you can see that caramelization, that almost necrotic-looking, unhealthy stuff you actually want to leave on. Tend to just rinse it and then reapply the next graft. The previous slide was small intestinal submucosa 7 days after treatment. You would just want to make sure you do not call that infected and not remove it. One of the new areas of research is using debridement with negative wound pressure therapy. As a plastic surgeon, sharp debridement is my favorite thing to do. If you give me a 15 blade, I'm extraordinarily happy. When you think about in the outpatient setting versus the inpatient setting, when I'm in the operating room, I have a bovie. I can do a complete debridement in the OR and stop bleeding. I can go half a centimeter or a centimeter into healthy tissue. I can then flap and reconstruct, and I'm not afraid of the size hole I have. When I'm in the outpatient setting and I perform a debridement, I do an amazingly good macroscopic debridement. My endpoint's bleeding. My endpoint is not complete debridement. And I think most physicians in the room will agree when you have nothing other than a silver nitrate stick to stop bleeding. You have to be very cautious not to get into a vessel or not to create something that all of a sudden you're sending a patient to the operating room or to the emergency room. And so we have to have something to help bridge that macroscopic to microscopic debridement. And collagenase is one of the things that we use. The FDA label for negative wound pressure says that you want to completely debride the wound bed prior to doing it, replacing the negative pressure device. We all know that can't always be done. It's a reality not to have it completely debrided. Oftentimes when you do that debridement it's very painful in the outpatient setting, and so you're doing these dressing changes at the bedside. The physical therapists are doing it, and so the question becomes, what else can you do? Well, collagenase ointment has now been shown to possibly be effective in conjunction with a wound vac. This is in wounds from March of 2015. Anecdotally, by the way, it seems to prevent the sponge ingrowth into the wound base. This was Dr. McCallan did a retrospective study last month. It was comparing Clostridial collagenase and negative wound pressure therapy in long-term acute care. His N value was 67 versus 47. The patients were standardized. There were no significant differences between age, etc. These were all stage 3 and 4 pressure ulcers, and they all had the same offloading management of their nutrition, diabetes, etc. They used a standard tool, the Bates-Jensen tool, to evaluate the patients. And what they found was that the patients who had the Clostridial collagenase seemed to have less necrotic tissue in the wounds at the negative pressure changings. We already spoke about this a little bit. When we are looking to bridge the gap between what we do in the operating room, or what I do in the operating room, versus what is done in the outpatient setting, oftentimes we will use a product. There's only one advanced modality for debridement, and that is Clostridial collagenase. We have lots of grafts. We have other advanced modalities to use once we have a patient debrided, but this is the only advanced modality for it. Dr. Motley out of Texas did a study, and this was presented in Wounds last year. And essentially what he did was a 12-week study. The first 6 weeks, well, the second 6 weeks for supportive care, I don't really want to talk about that. It's the first 6 weeks that are interesting. When you look at his study, he said, I'm going to do a study and take patients with sharp debridement and a dressing in one arm. And the other is going to be sharp debridement weekly as well, but using collagenase ointment daily in between and a dressing. So it's sharp debridement only or sharp debridement weekly with collagenase. They also used a standard tool. And they looked at the wounds saying, we're going to have two endpoints. We're going to have visual inspection by the person looking at it, the physician. And we're going to decide, do the wounds look better, whether it's just sharp debridement alone or whether you have the two together. And what they found was there was no statistically significant difference in visual inspection of those wounds on a weekly basis, regardless of what you did. The one thing that they did find was that the Clostridial collagenase patients had a significant reduction in surface area and compared to the weekly sharp debridements. And it was quite a big difference. And the one thing I will tell you, the p-value for the Clostridial collagenase in conjunction with sharp debridement was less than 0.001. It was excellent. The other one was not statistically significant. They're actually redoing the study with a 200-patient cohort. My reason for putting this in here is that when you think, and in my practice I see this, you have that macroscopic debridement. Remember, this is in the outpatient setting. You have a macroscopic debridement. You have to bridge and use that microscopic debridement in order to get your patients better, faster. And it really does seem to work. Debridement in PGDF, some people use PGDF in their diabetic patients. There's really no data on debridement in between applications when the patients come in. Typically, I try not to debride the patients that were getting PGDF for their diabetic foot ulcers. They seem to do better with just letting that go unless there's obvious necrotic tissue in the wound. But letting the PGDF do its job to close the wound tends to work better. And that's it. Thank you very much.
So there are a couple things. First of all, I'm vertically challenged, so if you can't see me up here, I apologize. When I was asked to give this talk about health economics, I was thinking, boy, this is a really complicated subject, and I have 10 minutes to do it in. But then I realized that everything I wanted to know was really, my mother taught me. So the first thing your mother probably taught you and taught me, and our employers are telling us now, is that money doesn't grow on trees. So as Dot said, the cost of wound care actually is over $33 billion in this country. So my mother would also say it would take two to tango. And so when you take people with wounds and then add on what we see in the U.S. healthcare population, we're getting older, we're getting larger. What does that mean for all of us? It means actually everybody in this room has job security until the day you fall over and cease to breathe. But it also means that where there's smoke, there's fire. And so chronic wound complications are associated with all of these things. But when you start looking at the data for the people who return to the hospital within 30 days, over 25% of them have a wound. That doesn't mean that there's a correlation between the two. It means these patients are the sickest of the sick, and they're not healing their wound because they usually have some other underlying comorbidity. Additionally, we know from the data that it actually, we have a higher 5-year mortality rate for a patient with a diabetic foot ulcer than those people that have either breast cancer or colon cancer. And so that's pretty frightening. So we actually take care of the sickest of the sick. So the things that we always hear from our mother was don't throw good money after bad. And so we have a huge reluctance in the U.S. to use healthcare economics. We see this trend of changing from I am taking care of this patient for my 4.8 days in the hospital and my 30 days in the LTAC setting and my 100 days in the long-term care facility to we are going to be transitioning our wound care to the episode of care across the continuum. We will get one payment and we will be penalized if we don't meet outcomes. And this is our future. So we need to start thinking about healthcare economics. So there are a lot of reasons why we have not really quite looked at this in the detail that we want. One of the reasons, especially seen in wound care, is that there are so many ways that we get so many treatments. So we can use a medical device, and that can be a class 1, class 2, class 3. We can use a biologic, such as cell-based therapies, or we can use a pharmaceutical agent, or we can do a combination thereof. So that confuses things, and it's hard to start looking at apples and oranges. There are lack of real-world randomized controlled trials. The Motley study actually was very real-world because the hemoglobin A1C allowed in this study was 12%. Now that's almost double what the expected standard of care is. But this is really what we deal with on an everyday basis. Now, as far as reimbursement, we all as clinicians go, okay, I would like to use XYZ, but am I going to get reimbursed for it? Am I going to lose money on it? Because if we start using technology that we actually cannot support financially, then we too will be out of business. And then there's differences between CMS and FDA and the AHRQ. AHRQ actually will look at health economics as part of their evidence-based guidelines and their recommendations. The FDA and the NCMS does not, on purpose, look at cost effectiveness in terms of when they are going to approve payment or approve a product or technology out on the market. So there's a disparity there. If you look across the pond at our folks in Europe, we actually see that they have a national health service or some type of government-run healthcare system, and cost effectiveness is part of that approval process. It does not happen without that. So when you start looking at the costs of wound care, we have to look at both direct and indirect costs. That's really the most simple way. The quality adjusted life year, actually several years ago there was regulations in our government that actually prevent us to look at that. So really we should be looking at cost effectiveness. Now again, when we start looking across the pond, our European colleagues have actually been very experienced about doing this for quite some time. They have been using Markoff Modeling to get the incremental CE ratio, or the ICER. So really, what does all that mean? Because the nice thing about using this model is that you can compare apples and oranges. So really, Markoff Modeling actually uses transitional probabilities to get from one state to another, which is very perfect for wound care. Because remember, our FDA outcomes really at this time is complete closure. But think how we go through wound healing. First we have to get rid of the necrotic tissue, then we have to get a granulation state, then we have to epithelialize and close. So you can actually plug in a mathematical model and determine how many states. So you can also decide, so your outcome or your benefit is standardized and reported in ulcer-free weeks or days, depending on how you've set up your model. But typically what we see across the pond and that we're seeing here in the limited studies that we do have in the U.S. in wound care really models 1 year period. So how many days of that year or how many ulcer-free years do you have? So now that ICER, once you have your benefit, you have to figure out what your ICER is. And this is a very, very simple calculation because, again, it's the cost of care versus the cost of benefits. So if product A is $1,500 and product B is $900, $1,500 minus $900 is $600. The ulcer-free weeks, that's your benefit, is the difference of 3. So 600 divided by 3 is $200 per ulcer-free week. So then the question is what are you willing to tolerate? And each system has to decide, and that's where our real limitation is, and is the limitation in across the pond. But they have actually said we are going to spend 30,000 euros. And if it's less than that, it's okay. If it spends more than that, there is no good ICER for this. So, but in the U.S., we haven't really come up with the standard on what that level should be yet. So there are a number of studies out there looking at cost effectiveness and Markoff modeling in using collagenase. So I'm going to go through both the clinical as well as the economic. Now, Dr. Bain has really done very well looking at this presenting Motley study, so I'm not going to go through the clinical piece. Let's start with Motley. So when we look at the 3-state Markoff model, so we're starting from the necrotic tissue, going to granulation tissue, going to epithelialization. So there actually are about 6 weeks, 6.7 weeks in difference of healed wound over the week. So when you look at the cost using collagenase, surgical sharp debridement, and standard of care, the cost is lower than standard of care, which is surgical sharp debridement weekly and offloading alone. But when you then add your ICER, so your estimated cost per ulcer-free week, so again, you're leveling the playing field and now looking apples to apples rather than apples to oranges, you're actually spending $61 to get an ulcer-free week as compared to $85 using surgical sharp debridement and standard of care. So that actually shows you that per ulcer-free week, it is more economical to use collagenase with surgical sharp debridement and standard of care. Let's move on to Milne. So we did 27 patients with pressure ulcers in long-term care, and what we were looking at is first endpoint was time to complete debridement. We had a day set at 42. When we looked at these, we had 85% people having complete debridement versus 29% in the hydrogel group. This group did not get any surgical sharp debridement from the time of enrollment. So this is interesting because we're not doing a surgical sharp debridement, which is really how we should be practicing based on the data. But this was data generated because in 2007, when we started the study, you didn't have people going into long-term care facilities on a weekly basis. So when we looked at the 3-state Markoff model and looked at the episode of care, we had actually a 17-day incremental effect of going from the necrotic state to the granulation state. Now, really, the acquisition cost of collagenase was greater, but when you, again, put the Markoff modeling in, it actually costs you $12 for an ulcer-free day using collagenase versus something a lot more in hydrogel. So when you're looking at the average cost-benefit ratio, $78 per ulcer-free day versus 249. And that's because hydrogel takes so long to debride and get to that second state. When we went to the second part of the phase 2 of our study, we looked at closure rates. And so we had, when we look at the intent to treat population, 69% of those people closed versus 21% in hydrogel. But when you apply your Markoff modeling, you have to actually look at your 50th percentile. And so then you apply your days. So really 50% of those patients closed by day 40. And again, 119 days for hydrogel. So that actually increases your costs. So when we looked at this, the, again, expected number of days with the effect, so a difference of 99 days in terms of healed wound time. And so when you look at your costs, although you have a cost savings of $3,400 per pressure ulcer, again, applying your ICER, it costs you $6 a day using collagenase without surgical sharp debridement in pressure ulcers in long-term care to get healing, or ulcer-free days versus $25. So there's clearly a huge economic benefit there. So with that, I want to again stress that we should be stopping not thinking about your own individual silo. But my mother would say that sometimes the most expensive treatment is the one that doesn't work. And then the second thing she would say is when we do our work, it costs an arm, and it really may literally cost a leg. So with that, I want to open this up for questions and a penny for your thoughts. Thank you very much.
I'm sure as a plastic surgeon you do several procedures that are staged, maybe a debridement with a skin substitute, and you come back and do a flap. My question is in regards to one patient having 2 admissions, 2 separate procedures in a 30-day period. Is that becoming a problem with this Medicare reimbursement, hospital not getting paid for a readmission? How do you get around that? Do you document that this is a stage procedure, et cetera?
Well, so the question for those of you who don't do inpatient coding is with all of the changes in Medicare and with the risk of complications and the need for multiple procedures in these patients in the inpatient setting, how you manage that. And I think it's an excellent question. Really what you have to do in your operative dictation and in your notes is, one, say that it is a staged procedure or that you expect there to be need for another surgery. Anything that has a high risk of a complication or even a pressure sore that brings a patient back to the hospital, it's entirely about your documentation. And so, when I do reviews of charts for pressure ulcers, and when I, whether it's for the California Medical Board or for the hospital, really what you're looking at is the documentation that says why it happened, if it's unavoidable, was it avoidable, were the appropriate things done to do it. In the case of pressure sores specifically, it's all about the documentation and saying that you're going to need to come back or have a high risk of recurrence. And then that's defendable. Yeah. The question was for Dr. McCallan's article that was just published in Wounds on wound vacs or negative pressure with collagenase. He actually puts it right into the base of the wound and the sponge right on top of it. When I spoke with him, I've actually started doing it, my own personal, I've started doing that. And I find that when you do it, you get a lot of fibrotic tissue out of the wound, a surprising amount. It doesn't seem that a lot of the collagenase is actually absorbed into the sponge. It seems to stay down in that neighborhood, and it really does seem to work. So I've actually started doing it since I became aware of his article. The question was, how much collagenase are we putting in? The standard amount. I know the company recommends 2 millimeter a nickel thickness. None none of my patients and oftentimes the nurses really understand nickel thickness. I tell them Oreo cookie thickness. For some reason, everyone seems to understand that better in this patient population. So, but just the standard thickness. From edge to edge, yeah, just into the base of the wound. Other questions?
In some of the large wounds, when you only have a small area that you still have the slough and you want to get rid of with the Santal, can I put a collagen dressing on the other? Will the Santal eat that, or will it leave it alone?
Are you saying are you talking about a collagen,
Like
an advanced program? I would never do that. I think you have to make a decision in your note or in your own mind. And in my mind, the question was, can you use Santal in conjunction with tissue grafts or collagens? The indication for those grafts on the whole would be you've had complete debridement. And so one of the...
Well, I'm not using that. I'm using Promogram for the healthy tissue.
So if you're using Program
healthy tissue on the other side, and there's only a small area.
Then you can, if you're not mixing the two, It can't hurt anything.
Will the Santal eat Promogram?
Definitely
will it break it down?
So a lot depends on what type of collagen dressing you're using. Again, Dot has talked about the Jovanovic article. You really need to look at compatibilities, and the collagen dressings are addressed in that article. So if you're using Promogram, it's one day, but your purchasing agent decides to use something else the next day, you can have that article because it discusses a number of collagen products.
Okay.
I think whenever we're looking at mixing these dressings, when you move on to a collagen dressing, generally you have a clean wound because now you're wanting that collagen dressing to encourage some change in the wound in terms of healing. So if you still have a lot of debris in there, you're going to have a hostile environment, and it will likely not the collagenase break it down, but the MMPs and the things that might be generated as a result of the activity of breaking down the tissue. You're probably just putting bad money after good. What did your mom say? Something like that. So it would be better just use it until the wound is clean and then go on to something like a collagen or even bioengineered tissues. The wound will be much better prepared for you at that point in time. Yeah. And I've heard of a lot of people that seem to think the two in combination. And, it's what works in your hands. It just, make sure that depending on the amount of debris, that it just makes sense.
This question is for Catherine. I'm over here, sorry. The economic modeling that you're doing is really interesting. Do you find that a lot of hospitals are using it to analyze, or probably not, right?
No, they're actually looking, my experience is that people look at direct costs. I don't want to, for my 4.8 days, I don't want to spend X amount of dollars when I can get away with Y amount of dollars, because nobody's really looking at the episode of care and in terms of repeat hospitalization. So there's really very few people, especially in health systems, that are looking at, at healthcare economics from the really correct way of doing it. It's probably the right way of saying it. So that question, I guess, for those at home was, if they did not hear, the question was, are people looking at, in my experience, am I finding people looking, using Markoff modeling in everyday practice? And that the answer is unfortunately no.
Catherine, this question's for you. In your hydrogel versus Santal study, did you use any hydrogel on the Santal, or were they exclusive completely?
They were exclusive completely. So the question was, did I use collagenase with hydrogel, maybe to promote the right moisture content, or just alone? They were completely separate.
One thing I will add on that, and I'm not sure if these case studies would be available at the Smith & Nephew booth, but we have in our slides, if you speak promotionally for them, there's a great case that was a dry eschar where they covered it actually with a sheet hydrogel, and the results were remarkable inside of a week. So if you have an opportunity to see that case, I would encourage it in terms of how far you can move somebody along inside of that 4.8 days or inside of a week.
Can you tell me how long you're continuing to use the Santal after the wound bed appears clean
The recommendation in the package insert is to use it until a granulating bed has been established, basically. So if you see granulation occurring and the wound is moving on and healing, then likely you've got it effectively clean and can move on from there.
Yes, but the pictures were showing that you used it clear to epithelialization. Is that true or not?
The preclinical data that we're developing currently, I think, teach that the enzyme is active and actually is an active healing entity. And so one might presume, of course I'm not a clinician, one might presume that if you left it or continued to deliver it, that it would continue to generate the active fragments that we know are pro-healing entities. And so there's that.
I'll weigh in on this one as well. So the endpoints in my practice for collagenase, and my protocol tends to be treat someone immediately with antimicrobials for 10 to 14 days, stop all antimicrobials, including silver dressings, everything. Switch over to enzymatic debridement with collagenase, daily, weekly debridements. Once they're granulated, I actually will tend to stop the collagenase, as that's the end point. And remember, that's a debriding product. And the FDA indication and everything that is in the literature primarily is it's a debriding agent. And there are other advanced modalities, because it's an advanced modality for debriding, that will get you healed faster. And so there's a whole spectrum of those, as we all know. And so I would move out from one into the next as soon as I have a good granular bed that doesn't seem to be fibrotic anymore.
Yeah, my question is about biologic debridement. I have not seen much data or anecdotal conversation about biologic debridement as compared to enzymatic debridement, either days to complete debridement or the economic ramifications of it. So can any of you comment on that?
So the question is has there been some comparative effectiveness data looking at biological debridement larvae versus collagenase? So in the U.S., there have not been any comparative studies, and in Europe, there have not been any comparative studies because they don't have collagenase over there. But they do have cost-effectiveness data on larval management or bio debridement. So that data is available in Europe.
This question's aimed more toward Dr. Bain. On a patient that is going to need surgical closure, either a large flat open wound that's going to need a skin graft or a decubitus that's going to need a flap, can you think of any, or would you use, I won't say it that way, would you use collagenase or would you just surgically debride it and then go ahead and close the wound?
So the question for those at home, there is, when I have someone who has a pressure ulcer that needs to be flapped and closed, would I use collagenase in lieu of surgical debridement? I think my preference typically in the standard of care would be to take them to the operating room, put them prone, and do the debridement sharply, check the bone for osteomyelitis, put a wound vac on it to temporize, wait for final cultures, and then once I'm sure there's no infection, to flap them closed. In the outpatient setting, oftentimes, as I really like to think of it very simply, is if I'm not going to take someone immediately to the OR, I will debride them sharply, very carefully, in the wound center or in my office with an endpoint of bleeding, just a little bit of blood really, and then use collagenase in the interim. But the standard of care would be to take them to the operating room. I would cut that eschar off the first day that I see them, and literally until I have bleeding, I will keep cutting. Within reason, obviously, I want to make sure that they're revascularized and that that's not why they're not bleeding, but I would remove that eschar sharply if I could. If they have too much pain, I would put collagenase on it right away if they're not infected.
Okay, great. We just have two questions from the web audience. One is short, and I think one is a little bit longer. The first one is by Laura Roca at Saudi Medical Services. The question is, can we use collagenase under Uniboot?
The use of Collagenase under any kind of compression, I think we all understand that the daily application is going to be the ideal. Have any of us ever used it under a multi-layer wrapper in a boot? Well, yeah, we do from time to time, and we'll usually cover it with a pigmented foam dressing, and we have really good results. But you're only going to get about a 24 hours activity on the enzyme. So you really got to think how much necrotic tissue is there, and is it really better to try to use some other compression where they can apply it daily until you establish a clean wound.
Okay, thank you. And the second question is by Catherine Krenz from Centegra McHenry Hospital. Have you used Santal CCO in treating deep tissue injury wounds that begin to evolve into non-viable tissue? And what is the best or suggested cover dressings to use with CCO? For example, saline, dry gauze, or foam. And she said she works in acute care.
Okay, every suspected deep tissue injury has its own level of evolvement. So when I actually see, in my personal practice, when I actually see this evolve into necrotic tissue, I will then start the application of collagenase. Again, the secondary cover dressing really depends on the location of the wound, how large the wound is, and how much exudate you're having at that point. It's really what I find in these evolving deep tissue injuries, early on when the necrosis starts, when you go from purple to black, actually there's very little drainage up front. So I'll have a tendency to use something that is probably less expensive. You don't need to collect a lot of exudate, but as this area evolves, you actually will get more necrotic tissue and therefore more drainage. So with that, our time is up, and we appreciate everybody coming today. We appreciate the role that NACCME has provided. And remember, you must go to the website to fill out your evaluation. Again, thank you very much.